and I'm the Director of Marketing at WellBe. We're happy you've decided to join us today for this webinar, Total Joint Replacement, Improving Day of Surgery Efficiency and Throughput. A few housekeeping details before we get started. This webinar is being recorded, and you should receive a link to the recording and the slides tomorrow by email. Please feel free to share this webinar with colleagues who could not attend today. Question and answer session will immediately follow the speaker's presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by WellBe's Guided CarePath. A guided CarePath helps automate patient preparation and follow-up activities through the entire journey of a joint replacement. Key check-in points along the surgery journey can provide risk flags for patients who may be off track and require intervention to avoid additional costs. Reports give administrators insight into how their programs are performing. To request an executive briefing on orthopedic service line automation and how it can help your program, please visit us on the web at wellbe.me. Now I'm going to introduce our speaker for today. Sandy Nettrour has specialized in orthopedics for 30 years. She's the Neurosurgery and Orthopedic Service Line Coordinator for Butler Health System, providing oversight of the business aspects of these two specialties while continuing to first assist in the operating room and provide patient care at the bedside. Sandy, I'm going to hand it over to you, and you can take it away.
Hi, everybody. Thanks for attending the webinar. I'm not exactly sure what all of you do, but I assume if you're signing in on this that it is a subject that you probably deal with every day. Surgical efficiency has been an ongoing problem for all of us for many years, and I like to think that hopefully I have something a little unique to offer you in some ideas and concepts about our surgical efficiencies that we use here at my hospital. And it won't go down.
Just click right on the slide and then try again.
There we go. I found it. Okay, so let's get acquainted. So you know a little bit about our hospital, Butler Health System, Butler Memorial Hospital, where we're located. We're in western Pennsylvania, and if you look at this map, we're north of Pittsburgh, almost a half of the way to Erie, I guess. Pittsburgh is an interesting demographic for healthcare. We have UPMC, University of Pittsburgh Medical Center, who has pretty much bought up all of the hospitals in the surrounding area, south to the West Virginia line and north to Erie. We maintain ourselves as an independent community hospital and are not involved with UPMC. The other thing that you may, if you follow Becker's or follow anything in the news, you'll see that Highmark is making a big presence, and currently Pittsburgh is embattled between these two giants, Highmark and UPMC, each trying to get their sharehold of the area. And Butler has tried to remain silent while they battle it out. We accept both of their insurances and their patients in our facility. Our hospital has 297 beds. We have 12 main ORs, and then we have procedure rooms where we do our cystoscopies, colonoscopies, etc. separately. We have one large OR group, and we have a minimum of 2 orthopedic surgeons that work in the operating room daily, sometimes 3, and also somebody doing spine. This large orthopedic group that we have at our hospital has 12 orthopedic surgeons, and also in their practice they have 6 physical medicine rehabilitation specialists, 1 rheumatologist, 2 primary care sports medicine physicians. So as far as an orthopedic practice, they're a pretty big monster. They have 9 of their surgeons that work regularly and weekly at our hospital. We do about 500 total joints a year. So some things as a background. Did you know that on average, hospital surgical suites waste over 30% of their capacity due to inefficient processes? Average costs are 20% higher than they should be due to poor utilization of staff and equipment and supplies. Total joint surgeons' professional fees have decreased by 36% since 1991. So the orthopedic surgeons are really taking a hit and really feeling the pressure as far as their income and maintaining their practices goes. Total knee replacement surgery is projected to triple over the next 15 years, while overall total joint surgeons are in decline. Orthopedic fellowship programs for total joint are not full, and with this professional fee decrease that continues to be ongoing, this tends to move people away from this field. So why is the surgeon grumpy? Well, the average surgeon only spends 60% of their time performing surgery while in the operating room, and on average, 70% of first-time surgical cases start on time. And the surgeon's main complaint is lack of a collaborative surgical environment. So if you look at this picture, and it's kind of a funny picture, and luckily it was the end of the surgical day, but what it's showing is in our surgeon's lounge, we have 2 surgeons and 3 physician assistants hanging out in this picture, which in my mind, when I walk into that lounge, tells me that there are 3 to 4 OR rooms that are sitting idle, with none of them producing any work. And that makes me start to walk around and try to figure out what's going on. So these are our main topics we're going to talk about today, universal issues. First one is inherent conflicts, patient preparedness, surgical start time, case efficiency, turnover time, and 1 or 2 rooms. So let's talk about inherent conflicts. This is what I like to call the hospital salute. I think every one of us who's ever been in a hospital has seen someone make this maneuver. The other one I like is somebody pointing in 2 different directions, and it's never at themselves to accept blame. And on the left-hand side here, we have all of the players that can derail an operating room day. So with our pre-op staff, issues, they tend or can have slow processes or preps, getting the patients prepared. Oftentimes they're waiting for labs or meds. Their patients have questions. Their nursing assessments are incomplete. They always seem to be waiting for something or somebody else to complete a task so that they can finish their work. OR teams. Issues are they may not be specialized. They may be in an orthopedic room this day, general surgery room the next day, etc. And the other thing is that they work by hourly wage. So as far as your OR teams are concerned, it doesn't matter whether they do 16 cases or 2 cases in a day. They will punch out at exactly that same time they're supposed to and take home the same pay. And the other problem that I find is if they're too efficient and they finish their day early, they tend to get downsized, which is not in their advantage either because they're losing pay. How about the anesthesia team? Well, if they perform slow blocks, if you have anesthesiologists that are trying to do 2 tasks, preoperative blocks, and anesthetize in the operating room, sometimes, or in my facility, commonly they have students with them. Students always take longer. And another issue that I have seen is poor staffing for case volume. So they tend to be pulled in too many directions. maybe haven't planned for a busy OR day and have not brought in enough team members, anesthesia team members, to get the tasks done efficiently. Surgeon, well, the surgeon has to be on time. That's not always necessarily an easy thing to accomplish. And the other thing is that their income is dependent on volume. So they always want to add volume, and this is a motivator for them. Central sterile. Trays aren't ready. Trays have missing items. Trays have holes. And all of this will slow your efficiency. Housekeeping. If turnover times are slow, if they are not trained to work in an operating room, this can be a main issue. Postoperative staff includes the PACU and the floor. If they can't receive the patient, for example, if discharge from PACU are not efficient, if the floor has not discharged patients and doesn't have rooms open to accept those patients, we can see our patients back up all the way to the operating room. So you have a patient on the operating room bed that you're recovering there because you're waiting for a room in PACU. Product reps can affect your day with late delivery of equipment, and if they're not involved in the entire process. If you have a rep who arrives in the morning and his job is to stand around, socialize with the surgeon, maybe open some packages, and accept his income or his percentage of the case, that isn't necessarily beneficial to the hospital or to the day. And administration, poor staffing decisions, and by that I mean maybe not staffing enough workers to get the job done. And they need to be involved with the day. They need to monitor the coordination between the different groups to make sure that everybody's doing what they're supposed to be doing. If you have a manager that is not involved, this is not a good thing. So, what did we do at my hospital? Well, back in 2008, when I started here, we created something called the operations team. And at the operations team meetings, which are held monthly, all team members sit at the same table. So each one of the people listed before is represented. I have a vice president that sits there, a surgeon, surgical teams, central sterile, floor nurses, case management, physical therapy, and they're all sitting at the same table so that they all hear the same things at the same time. There is not one member of the team that's more valuable than another. So the scrub tech's opinion is valued at that table equally with the surgeons or the vice presidents. They all have something to offer as far as information and perspective. Goals must be defined and understood, and you need to create action items with specific deadlines to get these action items done. And each one that's at that table needs to be empowered to institute changes or to initiate and complete action items. They need to be supported. And each one is accountable for that, their performance at the operations team. It's amazing when you get everybody together at the same table how one group affects another and doesn't have any idea how downstream they can mess things up. Patient preparedness. There's nothing like an unprepared patient coming to the day of surgery to slow things down and to confuse the works. So patients with many questions will slow your pre-op nurses because they've got to stand there and they've got to make sure that everything's explained. That includes anesthesia and anesthesia consent also. So our preoperative education here is critical, our preoperative pathway, making sure that patients receive layered information and reinforcement of that information so that when they arrive on the day of surgery, they know exactly what to expect. I had an anesthesiologist comment to me once that if they did not participate in our preoperative program as far as he was concerned, their surgery should be canceled. but he felt that strongly about the difference between a prepared and unprepared patient. Everybody sings the same song, and what I mean by this is every staff member from the office all the way through to discharge, every single person needs to know the plan, understand the mantra, and sing the same song, so that if a patient says, well, what day will I be discharged? And they're told they will be discharged on Thursday. All you need is to have one person walk into that patient's room and said, well, we'll see how you're feeling, maybe Thursday or Friday. That patient will go on Friday. So like children, they're always looking for somebody to give them different information, and they will hang on that information. So everybody needs to understand the plan and follow with it. Don't do anything on the day of surgery that you can do ahead of time. This includes signing their surgical consent, doing their history and physical, laboratory work. Make sure that every possible area that can be covered prior to the day of surgery has been accomplished to minimize the work and holdups. One of the things that we like to do here at our hospital is every week we hold case review, and that's where we get a group together. And during case review, we go over the patient's medical history, laboratory work, any special needs. For example, if someone's extra tall and needs a big bed, any discharge issues, and sometimes we turn up that people's birthdays are going to be while they're here, and we make sure that we get them a balloon and we sing them happy birthday. So that goes a long way for patient satisfaction too. But this makes sure that everybody, again, in the staff is well prepared before the day of surgery. Surgical start times, the bane of all of our existence. One of the things that I know is you will never make up lost time. People say, well, yeah, I started 15 minutes late, but I'll catch up. Never seems to happen. Lost time is lost time. From hospital to hospital, surgical start times can be defined differently. So what does start time mean in your facility? This is something that needs to be defined at your operations team meeting. At my hospital, surgical start time means knife goes down. That is incision time, and in our hospital it is 7:30 a.m. And this is how, when we measure how different surgeons are performing or how our teams are performing, that's how we go. There's another hospital that I've been on staff at that to them surgical start time is wheels roll in the room. Well, that's okay, but I also know that when I've worked at that hospital, incision time is never before 8 o'clock a.m. And right there, you've lost a half an hour of your workday. So does everyone agree on start time? This includes your anesthesiologists, your surgeons. They have to be at the table and agree with that. And I have here paralysis by analysis. We have process improvement projects that we do at our hospital. Different departments take on projects. And twice we had surgical start time process improvement projects. And we gathered a lot of data, but nothing changed. So you need to capitalize on your data, you need to look at it, and you need to see how you can leverage that to improve. What we did with our data is we knew that if we measured how long it took to get someone ready, in other words, from wheels in the room to incision time, what was that and what was the average? And then we went back from 7:30, and that was our wheels in the room time. So if it takes half an hour to get a patient, get their spinal, get them positioned, prepped, and draped, then the patient needs to roll into the room at 7 o'clock. That will make your start time more reliable. So on-time starts will decrease the end-of-day overtime costs. They will decrease your case length because you are using staff that have a specific skill set rather than using staff after end of day, 3:30 for example, that are coming that do not have specialized skill sets. Pre-op, staff, nursing, holding, and anesthesia will drive your day's success. And anesthesia needs to contribute to case order if you want your day to be successful. They have a very good perspective on what it takes to get a patient ready for surgery, anesthetized, for the surgeon to do their work. And we found that this was an area in our hospital that as soon as we started to work in a cooperative fashion with anesthesia, between the surgeon and anesthesia, things just simply went easier. In our hospital, what we like to do, first of all, before we involve them, the way the surgeon decided to do things is he'd start with his hardest case and work to his easiest case, because he's going to get tired as the day goes on. And that made good sense until you talk to anesthesia, who said that the hardest case of the day is the hardest one for them to get prepared, do their femoral blocks, get the patient's spinal in, get the patient settled for surgery. And so what we did was we changed to start with an easy or short case, maybe something that has no block, a smaller patient, and then after you have your first 1 to 2 cases kicked off, then start with a hard case. That gives them plenty of time to optimize that patient for the surgeon. Some of the factors that we look at when determining case order, we look at pending labs. Is the patient on Coumadin? Do they need PreOp on the morning of surgery? Are they receiving vancomycin, which has a longer drip time, pre-op? What is their weight? Are there obesity issues? Obesity issues means difficult blocks and difficult spinals. And that's why I put this picture in here, because case order can make or break the day. I don't know where you work, but in rural southwestern Pennsylvania, this is not an uncommon sight in our pre-op and in our OR. Teams should know their numbers, and numbers can be discussed at your operation team meeting. And you need to track your case efficiency, and the people the stakeholders at the table need to know their numbers. So what is the on-time start accuracy? Are they starting at 7:30 or are they starting at 8 o'clock? What is the in-room to incision time? Because this, again, determines when the wheels should go into the room, because that'll be your average prep time. What are your turnover times? What are your average case times? The more consistent your case times are, the easier it is to plan the day. Case volumes and block utilization, by that I mean the operating room block utilization. Hard data tells a story, and finger pointing does not work. So if I point at somebody and say, well, we're late because of you, that doesn't work nearly as well as being able to show our data and why, for example, if we roll into the room late, then we make a notation as to why that patient came in late. And was it that we were delayed by a lab result? Is it that we were delayed by a slow nurse and pre-op, or was it anesthesia? But we need to start to look for trends in the answers to that. Each OR team member must own their contribution to a delay. And they, if they need help, if there are roadblocks that we need to reevaluate, this is a good time to do it. One of the things that we've done at our hospital is we have, regarding roadblocks and who needs help, is at the end of a case, there's multiple people that need to be called into the room to turn over the room. So you have housekeeping, you have the anesthesia aide, and what we have are something called vocera, which are a thing they carry around their neck. And we've made a new call group, so all they have to do is push the button and say turnover team, and then there are designated people who may be nurses aides in the sterile core who come in and start to help turn over the rooms to make things more efficient. The other thing we've done in our operating rooms is we've designed cleaning zones. So at turnover time, each person, circulator, scrub tech, anesthesia aide, housekeeper, all have designated areas of that room that they are responsible for, and those are the ones that they focus on the most. If anybody then needs help, they can help in another zone. So some other things I've seen over the years with turnover time is don't make a mess. The more messy that OR is, the harder it is and the longer it takes to clean. I have a sports medicine surgeon here who loves to carry on about his turnover times and how he wants the turnover time to be faster, but he also loves to spray his irrigation fluid all over the floor. It goes everywhere. The room is a great big fat puddle, and when I suggested to him that maybe if he didn't make such a big puddle, it would be easier to mop and clean the room, for a while he thought it would be a good idea to make more of a mess. That stopped after a while. He was trying to make a point, but the point he made was it took longer to clean his room. I think he learned that. Start to clean up during closure. We like to hand off all of our finished instruments, put things on the one table, and push it away from the sterile field because it's things we don't need. They can start to be processed and loaded into our cart so that it can go down to central sterile. We don't wait till the end of the case to do that. We don't throw anything on the floor. I think personally that's very disrespectful of the circulating nurse. We don't drop our gowns, our gloves, or anything else. Nothing hits the floor. It's either handed off or it's put in a basket. And therefore our floors are very clean during our cases. At the end of the case, I'm fond of putting the garbage can as close as I can to the end of the bed, roll all of the drapes up toward the end of the bed, and then dump them all together into the garbage can. This collects any bone fragments, cement pieces, all of that is rolled up, and it all goes in, again, to keep the floor clean and keep turnover time down. During our closure, that's when our scrub tech and our circulating nurse, who are specialized in total joint replacement, that's when they go to lunch. That's when they take their break. Anybody can come in and help. The scrub tech can help with closure, cut suture, put on the bandage, etc. It doesn't require highly specialized teams. They need their break times, and so we've found that this is the best time to do it. They do not like anybody else to set up their tables. So usually by the time the patient's out of the room and the room is clean, they're back to set up their own tables the way they want. We enlist help. If somebody's standing around, like I was saying, maybe a nursing aide in the sterile core, they come in to help us turn over the rooms. I also believe strongly that if the physician assistant is standing around and maybe has his or her feet up in the surgeon's lounge, there's no reason why they can't be in that room opening sterile packs and helping get the case set up. I've done that for years myself, and I think that that builds rapport with your surgical teams. And allow tandem work. We are not a place that waits for one task to be completed for another one to begin. So we have the patient come into the room while the scrub tech is setting up their tables, maybe finishing and opening up packs. We do not wait. The other thing we do is if there is a patient, if we have two rooms, if we have a surgeon working with two rooms, that surgeon calls for the next patient when they start to make their femoral cuts, so that we know that if we do it that way, we have exactly the right timing so that when he finishes the case he's working on, speaks to family, and returns to the second room, that patient should already be prepped, draped, and ready to go because we've allowed exactly the right amount of time. Streamline your trays. It's amazing what we open for a case and what we don't use. So if you take a look at my pictures here, the picture on the left, this is what our highest volume surgeon, this is what he would have open for every total joint that he did. This happened a good while ago, and it was at the request of our product rep and a conversation about streamlining trays. The surgeon, the product rep, the scrub tech, the physician assistant, the circulating nurse, all went down to Central Sterile, and the surgeon bought a bunch of pizza, and they opened up all the trays to take a look at them. And sitting there having a pizza party, they all decided what they needed, and what the surgeon said was, well, what do I use all the time? And they put those in one set part. What do I use some of the time? And then those got divided out, and then what do I very rarely use, and what do I never use? And once they got those all separated out, the 4 trays on your right is what he was left with. So this is now what's open, and you can just imagine the difference in turnover time if that's all you have to open. The other things is by only having 4 trays instead of 10 trays, hopefully you have less chance of having holes in your trays just by sheer numbers. All of these trays on the left are all immediately available. They are right outside the operating room door, and if he says, I need that particular instrument, we can have that in the room and open for him in less than a minute. So it isn't that he's suffering in any way. If he needs an instrument, we will have it for him immediately. Cost savings by streamlining trays. So the average cost to process a tray is about $35. If you do about 500 total joints a year, reduction of trays, this equals $105,000 annually. So you've decreased your return over time, you've increased your efficiency, you can do more cases, and you've saved costs and processing. The post-op and floor staff play a part in our OR efficiencies. So when you look at them, first thing is use only one order set. When I first came to Butler Memorial, started working here on the service line, I had 6 total joint order sets. And this causes a lot of confusion for everyone because one doctor did it one way, another doctor did it another way, and although it was a painful evening for me, I had the surgeons sit down together. There was more than one practice at that time. They all came together, sat down, and agreed upon one order set. This makes, again, the message very consistent for patients, staff alike. Consistent block duration decreases your stay in PACU, so the more specialized your femoral block anesthesiologist is, or your spinal block anesthesiologist is, the more consistent your surgical times are, then the more consistent your block duration will be. So that our spinals tend to wear off fairly consistently, and our patients are only in the PACU 60 to 90 minutes at max, usually an average of about 60 minutes. The floor in the morning sends the beds down so that they are ready and we can put our patients directly in them so that we're not transferring from stretchers to beds back and forth. Our ice packs, we use a knee wrap with ice packs in it. We send those up to the floor, 2 of them, so that they're already on the floor, frozen for the patient, ready to go. And although it's contrary to current beliefs or practice, we have a consistent discharge time for our orthopedic patients, and it's 11 o'clock a.m. That's the time we expect the family members will come and pick up the patient. One of the things that we do not do here, although there's a lot of literature to support it, is we do not heavily load our total joint patients to the beginning of the week. We do total joints here Monday, Tuesday, Thursday, and Friday. So usually our patients in PACU, those rooms have a patient in them, and we need to have those patients discharged so that we can get the new patients admitted. In addition to that, because I'm sure that's the question would come up, is we, with our consistent order sets and our consistent discharge times, we do not have a discrepancy in our length of stay between early week surgeries and later week surgeries. It's the same across the board. So to swing or not to swing, that is the question. Haven't ever met a surgeon that didn't want 2 surgery rooms. Didn't matter how busy they were, how light they were, they wanted 2 rooms. Surgeons always will tell you they will be happiest if they have 2 rooms. And again, that goes back to the fact that if you have a surgeon that's sitting in the surgeon's lounge and is not working, they are not earning money, nor are they earning the hospital any money as they sit there. So in our hospital, we developed criteria for swing rooms, and they are listed here. These are what our surgeons have to show if they want a second room, and we are able to accommodate that. So they have to increase their volume 10% within the first year. They have to have 75% utilization of their current block time. They have to have a first assist available to close the case they're working on. Patient safety is not compromised, and they are in the top 50% of their service line in volume. This is re-reviewed through the years or as time goes on. We continue to maintain this and watch what they are doing. So currently I have 2 total joint surgeons that work in our hospital every week. I have one surgeon who has no interest in having 2 rooms. He's perfectly happy with his 1 room and doing his day. So this is a map of his 1-room day. And you can see here he did 2 knee arthroscopies, total hip, 2 total knees, and he was finished at 2:45. That's a nice day for him. He's happy, gets a little bit of a break between his cases, which he appreciates. Make phone calls, do dictation, etc. And this is what he prefers his day to look like. This is a typical OR day for our one surgeon who has 2 rooms. He kicked off with a knee arthroscopy. Reason again is that allows him time for the second room, time to get the patient in, anesthetized and ready to go. We tend to schedule his cases hourly. So every hour on the hour, another joint is put on the schedule. And we can pretty much time this very closely, that's how his schedule will run. So his total count for the day was a knee arthroscopy, 6 primary total joints, and a hip fracture at the end that was added to the day, and he was done at 2:50. I did my best to try to map out a day showing what each person's job definitions are and when they are doing these jobs. Pre-op, I have their prep and block. We have an anesthesiologist who is semi-retired. He comes in every week. His job is to do the blocks. So we have an anesthesiologist and anesthetist in our pre-op area that do all of our nerve blocks. Not meaning spinals. This is femoral blocks, interscalene blocks, etc. So in pre-op, that maps out anesthesia. We then have an anesthesia team for room 1 and room 2. And then we have our surgeon. He is usually here, marks the patients, completes his rounds, and he starts his first case at 7:30. That is plus or minus 5 minutes. Again, you can pretty much set your watch by that. He leaves case 1. He circles out, says hello to the family of case 1. If need be, greets any patients that might be case 4 or 5, circles back, case 2 is ready for him to do, and then he continues to do that until his day is finished. And then we have down at the bottom OR staff. And what you'll see is when they're opening their cases, anesthesia is doing their work, oftentimes in the same room. They are given their spinal, and the OR staff is completing their opening of instruments. Our goal is to have our surgeon out of the OR somewhere between, depending on the number of cases they have, somewhere between 2:30 and 3:30. He does what he likes to call Hollywood rounds. He goes up to the floor, sees all the patients and their families, checks on them, shows them their x-rays, and then he should be out of here between 3:30 and 4 if there are no add-on cases for the day. So this picture of the gorilla, I did a presentation to the Pennsylvania Orthopedic Society, and it was about cooperative efforts in the OR, and I used this picture. I didn't get a whole lot of laughter from them, but I think that if you talk to any OR staff and a surgeon that's having a fit, which we've all seen, this is pretty much what you see in your mind. This does not spark a lot of confidence, and I think even the best trained scrub techs and circulating nurses, when they're confronted with someone behaving like this, will freeze and second-guess their actions. So each person can be the problem or part of the solution. The surgeon would be much better off pitching in and helping if they feel things are delayed than sitting back and screaming. Every person has a contribution, and each contribution has value. We are a strong believer here of using carrots instead of sticks and incentivizing our staff. So team building and what works, and are you kidding? I tell people this, and they really kind of think and this is where I'm a little bit different than most, but I really feel that if you incentivize your staff in a proper manner, that they will do anything for you, and they'll work as hard as you want them to work. But you've got to find a currency that works, and this doesn't mean paychecks. We can't change what they're going to be paid necessarily, but we can make their day a lot more fun. And anytime someone can come to work and have a lot of fun doing it, those are the people that will work harder for you. So I have some examples here. Milkshake races. When we were having difficulty with turnover times, we were using 2 rooms. The second patient in the second room wasn't ready on time. Our surgeon, he's the one putting the piece of pizza in his mouth there. The surgeon decided that we were going to have milkshake races. So it went like this. If anesthesia and the OR was ready before he was to do the case, then at the end of the day he would buy the milkshakes. If he was ready before they were, then they had to buy the milkshakes. So at the end of the day, our coffee shop here they would call down, get an order for milkshakes. And for the cost of about $15, everybody got to sit around at the end of the day, drink a milkshake, do a little bit of laughing, and everybody won. It's worked very effectively, and everybody has a lot of fun with it. Song games. We like to play music in our operating room, and what we say is, it's trivia pretty much. Who's singing this song, or what song is this movie from? And we'll include anybody in the room. That includes students. It tends to get them involved, and again, gives them more team spirit. We buy pizza. We have pizza parties for Central Sterile. This picture right here was just taken a couple of weeks ago in Central Sterile. We go down there, and we know them by name. Not very many people in a hospital know their Central Sterile people by name. Go down there, enjoy some pizza with them, have a good time. They greatly appreciate it, and we tell them we appreciate them. Mop stealing. Again, this was a while ago, but when we were having trouble getting our OR rooms turned over, and I do not have a picture of it. I wish I did right here. We would come out of the operating room, take a look up and down the hallway, and if housekeeping wasn't coming down the hallway, either the surgeon or I would run for the mop and the broom, and we would start to mop the rooms. Boy, does that get housekeeping's attention. We had a housekeeper or orderly in our OR back then. His name was Richie, and Richie was appalled every time he saw either me or the surgeon holding the mop and doing his work. And it got to be a race who could get to the mop fastest when the case was finished. He loved to watch our rooms to make sure that it wasn't us. And when Richie retired, our whole team took him out to dinner at Texas Roadhouse. We had steaks and had a party for our housekeeper who did such a wonderful job for us to tell us how much we appreciated him. Our floor staff, now every month there's a new theme, but these are some of them. The doctor's name is Muzzy Negro, so we have Muzzy Monday for a month where cookies are brought in for every shift. Tropical Tuesday, Wacky Wednesday, Thirsty Thursday, and Super Friday. Again, the idea is to explain to your floor staff or express your appreciation, even if it's the night shift, who you never may see. These people are a part of your team, and they need to know that they're being appreciated. It's kind of funny, but with all of this going on, some of the other teams in our hospital, cardiovascular, general surgery, etc., they tend to complain a little bit. They wish they were on the orthopedic team because their surgeons don't do these kinds of things for them. So in conclusion, OR efficiency is a collaboration. And if you look at this picture, in my mind, the person sitting in that race car is the surgeon. He's all revved up and he's ready to go. He's probably the highest paid member on that team, but he is no more important than anybody else on that team because he can't make that race car go if the person changing the left tire doesn't do it in an efficient manner. Empower team members to find solutions and recognize their efforts. When we have our team meetings, if someone comes up with a good idea, they are recognized in front of that vice president, in front of that surgeon, and everybody else that they have come up with a valuable idea to how we do things here. Break down barriers by leveling the playing field. Give each member of your team a voice. Appreciate their knowledge and input. Find a way to work harder, or smarter, not harder. And everyone wants to do a good job and be appreciated. If you appreciate them, they will work harder for you. And that is my presentation. Thank you very much.
Thank you, Sandy, for that informative presentation. We are now going to open it up for questions. So if you have a question for Sandy, please type it into the questions box in your GoToWebinar panel on the right side of your screen. While attendees are submitting questions, I wanted to remind everyone that today's webinar is sponsored by WellBe's Guided CarePath. The Guided CarePath helps automate patient preparation and follow-up activities through the entire journey of a total joint replacement. Key check-in points along the surgery journey can provide risk flags for patients who may be off track and require intervention to avoid additional costs. Sandy uses a guided care path currently to help prepare her joint replacement patients at Butler Health System. And here's an example of a surgery readiness survey that's delivered to patients 1 week before surgery. If they answer in the negative, it sends a flag that the patient might not be prepared and is in danger of canceling or slowing down the process. And then Sandy can see administrative reports over time of how her program is doing in preparing patients. If you'd like to schedule an executive briefing to learn more about how orthopedic service line automation could help your program, please respond to the poll on your screen. Now I'll take a peek at the questions. So Sandy, is there any extra measures that you're taking due to the age of patients in the case of multiple joint replacements? Anything, is this specialized for that audience at all?
In the case of what?
Are you doing any extra measures due to the age of the patient, or if there's multiple joint replacements? Anything special?
Okay, so I'm assuming what you're talking about is multiple joint replacements in the same patient, rather than multiple joint replacements during one day. Our average joint replacement age here is about 67. We do see patients in their 80s, some of them revisions, of course. And our youngest one, I think we have one in either this week or next week that's 48. But our average is probably in their 60s. Like everybody else, we see a lot of comorbidities, a lot of diabetes, coronary artery disease, obesity here. So no, not necessarily for our elderly. We take into consideration, I guess, our acute pain service, their age and the doses of their medicines. But they really pretty much follow the same pathway as everybody else. They come in on the same day. They're discharged at the same time. They follow the same rehab program as the others. They may have a tendency more to go to a rehab unit than go home, but other than that, not necessarily. We do not do a lot of bilaterals here. Our surgeons are not fond of that. We do them on occasion, but they are not necessarily great believers in doing both sides at the same time.
All right, Pauline wants to know, why do you use femoral blocks instead of intra-articular or pericapsular joint injection?
Well, with our multimodal, we do use a joint injection, pericapsular injection. We are currently using Marcaine. So we use a Marcaine with epi and without, with some morphine in it, and we do inject that prior to closure. And I'm assuming what you're talking about is the new intra-articular injection, lipozyme, something or other, that I've read about. The difference is cost. That is $500 an injection, and we just haven't transitioned over to it. Our patients do extremely well with their femoral blocks. Our femoral blocks are titrated so that the patient is able to straight leg raise, is able to get out of bed and walk the same day as surgery. So I think it has a lot to do with how you titrate them. But currently we found them very effective. I monitor our patients' pain scores. Currently and with my pain score monitoring, every reported and scored pain score that's entered into the patient's electronic medical record, I average those out. And our total knees currently are 85% pain scores are between 0 and 4, and less than 10% are 7 to 10. I'm a little reluctant to change our regimens when we are that successful.
Mm-hmm. You asked, what did you do to address patient pickup by family and ambulances?
That's always a big problem, and so I'm old enough now that I can remember the old days. I mean, I think, I kind of laugh at myself when I say that, but back in the day, we had a firm discharge time for patients, and nobody ever questioned it. It was just the way that it was. Nowadays, patients come and their family comes and gets them whenever they feel like it. Well, I'm going to work. I'm going to go pick up the kid at, at soccer, and then I'll be around later to get mom. We don't do that here, and we start that all the way back at the very beginning with our education that our firm discharge time here is 11 o'clock. That goes for ambulances too, and we keep a running spreadsheet to see if someone is discharged past 11 o'clock, then I want to know why, and we track that. So if it's because the PCP did not round efficiently, if it's that the ambulance service was late, whatever the reason, I'm tracking that data and I can address that with that specific group. Families, they're simply told if there's a day you need to take off of work, it's the day mom goes home, not day of mom's surgery.
Great. Scott asks, what are you doing to better prepare patients prior to surgery?
So our program, our program starts way early. Ideal pathways for total joint replacement should be starting 6 to 8 weeks in advance of surgery. It starts in the office with some education. It includes enrollment in the Total Care program or the WellBe program that we call Total Care here, that provides the patient with timed instructions and that they can read just small bits of information. We then bring patients into Joint Camp where they receive, again, reinforcement of all that information plus some additional information. So we reinforce it again. When the patients come into the hospital, when they arrive on the floor, they get a newsletter. It maps out every single day and what they can expect to happen with their daily schedule, which reinforces that information again. And then the Total Care program follows them afterwards and reinforces information. So to me, it's a layered reinforcement of information that starts way early and never quits.
Great. Linda wants to know, what is your average turnover time between cases for joint replacement?
It's a little difficult for me to measure because our guy with 2 rooms, his turnover time is 0. So if we discount him, our gentleman with 2 rooms, I showed his schedule, and it said there 21 and 24. When I average out his cases in a day, our average turnover time is 17.5 minutes.
Awesome. Shannon says, great presentation. How did you get everyone on board, i.e. the anesthesia team, pre- and post-op team, to follow a consistent, streamlined process? Was there resistance? And if so, how did you overcome it?
There was a lot of resistance, and it took a long time. And none of it's easy, and none of it will ever be easy. I mean, you have to constantly revisit it. You have to constantly retweak it and improve it, or go back and redo, or adjust things. So it's never easy. The biggest ways to make a change are you need to have an administrative champion who sees the benefit, and you need to have a surgeon champion who's willing and has the energy to participate. Hopefully enlist other surgeons, convince them. And all you need to do really is, if you start to show success somewhere, pick an area that you can show success. And once you start to show success in that one area, then you get credibility and people are a little more willing to follow along. And don't ever give up on your team meetings. You've got to sit down with your staff monthly, and you have to have a round table so that everybody can voice what their issues are, and so that as a group you resolve them. Don't start a team meeting just to solve, you problem solve something and then nobody meets anymore. It's got to be a consistent scheduled meeting that everybody attends.
All right, one more question from Kristen. She wants to know, what percentage of patients go home versus to a SNF? Is the consistent discharge time of 11 the same for patients going to another facility?
The answer to your question is yes. our discharge time is our discharge time, and it doesn't matter whether they are going to rehab or whether they are going home. So that's my first answer to your question. The second answer to your question is I am way behind on discharges to home here. We are probably at 60% of our patients go to a rehab unit, and that is because our surgeons do not, at this time, want to change and send them directly home. So I have, we have consistent. I have discussions, I shall say, with my surgeons about this, and I have for 2 or 3 years. They are resistant to changing that at this point. I think that I'm finally going to win that battle at some point here soon. But at this current time, they say, if it ain't broke, don't fix it. The patients are doing well. They're happy. Leave them alone. But I think the climate of medicine, they will be soon changing to discharging more to home.
Yeah. A little follow-up question from Mary. She asked, what steps did you incorporate to communicate that 11 a.m. discharge to the inpatient facility?
What did I do to communicate it? Is that what you said?
Yeah.
Okay. It starts back when they get their first information. So the very first information they get about surgery, it is said to them, your discharge time will be 11 o'clock. And then they come, then they get, they get that on their education at home. They get it at joint camp. That's when they need to be arranged. That's when their travel arrangements need to be arranged. They get it again when they come into the hospital. And that's one of those things that everybody sings the same song. Discharge time's 11 o'clock.
She was asking how you communicate it to the SNFs and rehab. That's part of your arrangement.
No, I don't recall. We've been doing that for a long time. We've probably been doing that, could be 5 years now. So I don't recall how we initially communicated it to them. We just told them that's the time they needed to be ready to pick up the patients. And our case management and our social worker made it happen. But I don't know if there's anything so long ago. I don't recall if there was anything particular they did other than just tell them that's when they expected them to be here.
All right. Well, that's all the questions we have for today. If you have questions you didn't have a chance to ask, feel free to email them to info@wellbe.me, and we'll get back to you. Watch your email tomorrow for the link to the recorded presentation and PDF slide set. Also, watch out for our next webinar. In May, we are doing bundled payments with Hoag Orthopedic Institute. If you want to sign up for that, go to orthoserviceline.com and register now. Otherwise, thanks to everyone and have a great day.